The next session is questions that are burning in our heart, points of contention. May I request the chairpersons to come over the stage first, Dr. Amit Roy, Pranab Kumar Bishwas and Dr. Alok Majumdar. And to save time, I would request all the four speakers to come on the stage and sit on that side, the first speaker being on the podium. They are Dr. Jayanta Saha, Bikash Majumdar, Achyut Sarkar and Mrinal Kanti Das. Please come over the stage, all of you, and please stick to the time of 13 minutes, 1-3, and we may take questions answer session at the end of the 4 lectures. Thank you.
Good morning, everybody. First, I must give thanks to our scientific committee chairman for giving me this opportunity to speak today. My today's topic is non-invasive testing for stable angina, how best to utilize. The purpose of the test is for diagnosis, for risk stratification, and for planning management. We choose the diagnostic test in such a way so that according to the pre-test probability, so that we have a right post-test probability. The diagnostic tests have different sensitivities and specificities. However, the pre-test probability is determined by the age, sex, and nature of symptoms. This chart showing that the patients above the age of 60 with typical angina, particularly men, they have a pre-test probability more than 85, while the patients with non-anginal and atypical chest pain having pre-test probability below 15, particularly in females below the age of 50, the likelihood of having coronary artery disease in pre-test probability less than 15 is very less, while above 85 it is very high. So our investigative procedures will be in between 15 to 85 pre-test probability. Now this is angina cascade, which shows that the initial perfusion abnormality may be picked up by thallium scan or technetium scan. The diastolic function can be shown by tissue Doppler imaging, while the systolic dysfunction can be pointed by the echocardiography, and thereafter ECG and angina comes in. Now, as we go higher up in the ladder, the specificity increases, while the low down, the sensitivity is very high. For most of the tests, we need a stress testing to increase the sensitivity and specificity of the test. Particularly here, exercise is more important than physiological because it has a higher physiological stress, and it has got a strong prognostic indicator, and it correlates with the patient's symptoms and work. So how do you choose the tests? Suppose exercise ECG, we use it for pre-test probability very high, more than 65. Because of its low sensitivity, we may miss some of the cases. So we should use it for pre-test probability less than 65. Now, patients between 15 to 85 pre-test probability. For 15 to 50, we go for CT coronary angiography. If it remains unclear, we can go to the second imaging mode. Or if there is a significant stenosis, we can go for diagnosis of CAT. However, for stress imaging with pre-test probability between 15 to 65, where the ejection fraction is good, exercise ECG is our first choice, while 66 to 85, or the ejection fraction is less than 50, stress imaging is of first choice. If there is no ischemia, it's likely a functional CAT. If there is ischemia, then the diagnosis of CAT is done. However, if it's unclear, we can go to the second imaging or CT coronary angiography. Chest X-ray not very helpful except for heart failure. Resting ECG may show LVH or LVBB. Helpful for future comparison or risk stratification. Resting echo, ejection fraction is an important prognostic parameter. We can exclude AS or HOCM. Tissue Doppler may help in impaired for finding out impaired diastolic filling, which may be the first sign of ischemia. Grossly dividing anatomical and functional imaging. Anatomical imaging, we go for CT coronary angiography, high sensitivity, specificity about 80%, preferable in PTP between 15 to 50. It has got a high negative predictive value. Not only here we get the diagnosis of stenosis, but also the amount of plaque, amount of calcium, and also if any vessel remodeling, positive vessel remodeling is there. It has got a less impressive positive predictive value because it overestimates the degree of severity of obstruction, particularly when the vessels are calcified, the limitations being high heart rate. Now, MR coronary angiography, the image acquisition is not as good as MDCT. Here, no ionizing radiation is there, and the vessel wall detection is not hampered by calcium. Those are the advantages. Now, for functional imaging, exercise ECG is useful for pretest probability between 15 to 65. Not only ST depression for diagnosis is used, but the workload achieved is also very important, because patients going up to a workload of 10 to 12 meds have a very good prognosis. Not of diagnostic value in LVBB or paced rhythm, false positive with LVH or electrolyte imbalance, less sensitive and specific for women. The limitations are further that the MPI helps in localization, exercise ECG doesn't. People who are unable to exercise, we can go for pharmacological stress again. Now, stress echo, high sensitivity and specificity, reversible ischemia may be shown by normokinetic segments becoming hypokinetic, necrosis remains akinetic as before. Necrosis with viable myocardium, the hypokinetic segment may have improved wall motion. Hibernation may show a biphasic response. Now, stress imaging compared to stress imaging, stress echo showing a wall motion abnormality is always more specific. The prognostic importance is also there, more than 2 to 3 segments affected or more than one coronary artery territory affected shows a bad prognosis. Contrast echo can be used for endocardial delineation of the borders. Myocardial perfusion imaging with contrast echo, not very commonly used, can also be helpful. Tissue Doppler and strain imaging can help in quantitation of the resting wall motion abnormality. SPECT, normally there is an increase in flow after stress about 2.5 to 6 times, but not more than 1 to 2 times distal to stenosis. So, a reversible defect can be picked up by low uptake during exercise and normalization and rest, and this is the hallmark of ischemia. However, in balanced triple vessel disease, the relative difference in the uptake may be subtle, which may be picked up by PET. The other uses are like LV function. It can be used in hybrid imaging along with CT coronary angiography. Here also we can get the bad prognostic features by knowing the amount of myocardium in jeopardy, and also the post-stress ejection fraction is less than 45. Now, cardiac MR, usually the degree of stenosis known from the coronary MR coronary angiography, used mostly for coronary anomalies, and the hemodynamic consequences from the stenosis can be known by dobutamine MR or perfusion MR. Now, perfusion MR is always more predictive of cardiac events than MR coronary angiography, while dobutamine MR is more specific for ischemia than perfusion MR. PET, both the myocardial perfusion and metabolism can be known. The major advantages are the high sensitivity and specificity, and the maximum advantage is that we can absolutely quantitate the perfusion and metabolism here, and thereby in multivessel CAD, where there is uniform decrease in the blood flow, where SPECT fails, PET may be of help. The disadvantages being availability of the cyclotron and also the pharmacological tracers which we use. They have a very short half-life. Only a pharmacological stress can be done. Now, regarding hybrid imaging, the coronary anatomy from CT angio, PET or SPECT showing functional consequence of the lesions, they can be combined to get the results in borderline and equivocal lesions. A sequential or an integrated approach can be done. In low pretest probability, first choice is CT coronary angiography. For intermediate lesions, it's MPI the next. For intermediate and high lesions, MPI is our first choice, and for equivocal lesions, CT coronary angiography is next. The major advantage of the hybrid imaging is that they have got a very high negative predictive value and accurately assess the pathological consequence of the disease. Those with significant coronary artery disease and abnormal myocardial perfusion, they have the worst prognosis in hybrid imaging. So, patients who can have intermediate pretest probability, interpretable ECG, and able to exercise, we go for standard exercise ECG testing, while intermediate to high pretest probability and uninterpretable ECG, we can go for stress echo or MPI. People who cannot exercise, we can go for stress nuclear MPI or echocardiography. However, class 2A indications for dobutamine echo for low pretest probability, for CT angio for low to intermediate pretest probability, and pharmacological stress CMR for intermediate to high pretest probability. So, this is in summary, pretest probability between 15 to 65, ejection fraction more than 50, exercise ECG of first choice, pretest probability between 66 to 85. Here, stress imaging is of first choice, and between 15 to 50, CT coronary angiography of first choice. However, if there is any confusion, we can go to the another mode of investigation. Now, FFRCT, this is another recent mode which is coming up. It provides a high diagnostic accuracy compared to that of hemodynamically significant coronary artery disease compared to that of invasive FFR. So in conclusion, non-invasive tests with different sensitivity and specificity used for appropriate pre-test probability can avoid unnecessary invasive procedures. Commonly used available tests like exercise ECG, CT coronary angiography, SPECT MPI have been brought already into the guidelines. However, in future, routine clinical use of advanced imaging like PET, hybrid imaging, and FFRCT, what we are looking forward to. Thank you.
If any question can be addressed later on after the four speakers deliberated. Next speaker is Dr. Bikash Majumdar. Systemic CV of uncertain cause, how far to go to exclude paroxysmal atrial fibrillation.
Good morning, chairpersons. Good morning, seniors and my colleagues. Ischemic CVA is a major cause of mortality and morbidity in our country. And we know that 1 in 4 stroke is actually cryptogenic stroke. So what is cryptogenic stroke? This is a broader term where diagnostic assessment can be incomplete, no cause been found despite extensive assessment, or there may be multiple potential causes such as concurrent atrial fibrillation and relevant high-grade stenosis of the precerebral artery. As this is a broader term, the new terminology came to actually describe a subset of patients who are called embolic stroke of undetermined source. What does it mean? It has got certain definite criteria to fulfill to diagnose this particular entity. It is actually a subset of cryptogenic stroke. So what are the criteria of ESUS? So stroke detected by CT or MRI that is not lacunar. So that is very important. So what is lacunar stroke? So if we get a stroke in the subcortical infarct, in the distribution of the small penetrating cerebral arteries, whose largest dimension is less than 1.5 centimeter on CT and less than 2 centimeter in MRI diffusion image, that is lacunar stroke. So ESUS is not lacunar stroke. That has to be established. Second, absence of extracranial or intracranial atherosclerosis. That is also very important when we actually diagnose ESUS. So there should not be any luminal stenosis more than 50% in the artery which is supplying the area of ischemia. Number 3, no major risk of cardioembolic source is identified. So either an atrial fibrillation or a flutter or intercardiac thrombus, intracardiac tumor, severe LV dysfunction or infective endocarditis. So you didn't find any of these causes, then that is one of the criteria to diagnose ESUS. And number 4, no other specific cause of stroke identified like arteritis, dissection, migraine, vasospasm or drug abuse. Then you diagnose the case as ESUS. And in spite of diagnosing this, what are the cause of ESUS then? So probably majority of this cause of ESUS is unexplained etiology or probably embolic form of unestablished source. We don't know where this embolism is coming from. So we know that 20% of embolic stroke is actually cardioembolic stroke. And among the cardioembolic stroke, non-valvular atrial fibrillation is one of the major cause of having cardioembolic stroke. So that's why we need to bother about detection of AF in ESUS, because paroxysmal atrial fibrillation may be one of the causes of ESUS, which is about 42.9% in this kind of stroke patients. So is there any relationship among the stroke AF burden and the causation of ESUS? Is there any relationship? There is no general agreement or consistent data to determine the relationship between the duration of AF and the risk of having stroke. Now, because data are very conflicting, if you look the trend study data, and they said that if there is a 5.5 hours or more episodes of AF, then that actually double the risk of thromboembolism, and if it is less than 5.5 hours, the risk is not that much. But on the other hand, if you take the data of the surprise study, you can find that 1 to 4 hour episodes of stroke, AF is actually increase the risk of stroke. And the most studies said even 5 minutes AF actually increases the stroke of chance of having stroke or thromboembolism. Boriani et al. Showed in a patient of AF who actually had a pacemaker, if we get an AF incidence of less than 5 minutes in the pacemaker detection, then the chances of having a thromboembolism lower compared to who actually have more than 24-hour duration. Similarly, Glotzer et al. Also find that increased AF burden actually increase the risk of having a stroke over the next 30 days. But these are conflicting data. We just cannot say about the duration of the AF actually responsible for having a stroke. So, it has been seen the larger we monitor, more is the chance of getting atrial fibrillation in this kind of patient of ESUS. So, we had certain observational data and we have certain randomized trial, whereby different clinical modalities of tests, we actually try to diagnose the evidence and the incidence of AF in these ESUS patients. The tests being ECG, inpatient continuous telemetry, Holter monitoring as an outpatient, mobile outpatient telemetry, and implantable loop recorder, all the modalities that we have to detect the AF. If you see, if you only rely on the admission ECG, we get about 2.7% in the ESUS patients, and you can actually diagnose the AF. If you increase in the inpatient non-invasive continuous telemetry for 3 to 5 days, that rate increases from 5.5 to 7.6%. At 24 to 48 hours, Holter monitoring only detects about 6.4% of the AF, and mobile outpatient telemetry up to 30 days detects up to 25% of the AF in this ESUS patient. And if you put an insertable loop recorder up to 18 months, you can actually detect 30% of these ESUS patients is actually having stroke. And if you take, these are all observational and retrospective data, if you take the randomized control trial, the 28 days of outpatient telemetry will give you about 16% patients of this ESUS will having atrial fibrillation, and the loop recorder can give an yield up to 30% of the patients. Now, two important study here I would like to quote. One is an EMBRACE trial, another is the CRYSTAL AF trial. The EMBRACE trial actually looked in the 572 patients who did a non-invasive ambulatory electrocardiogram monitoring, and at 90 days, you can actually have 16.1% patient can have an AF in this ESUS category of patients. And in the CRYSTAL AF trial, they actually put insertable cardiac monitor, and at 6 months you can see 9%, 12 months you can see 12%, and 36 months you can get 30% of the patients of this ESUS who can have atrial fibrillation. Now the question is, how long we are going to monitor these patients? What's the current guideline and how long? Is it cost effective to monitor each and every patient of ESUS for 36 months with an insertable loop recorder? That's a big question. Now, currently what we do 24 to 48 hours Holter record monitoring. And is there any evidence to suggest that we should continue for longer monitoring? There is no current guidelines to suggest that. Now, is there any subset of patients where actually we should go for longer monitoring, where we can actually have more chance of getting atrial fibrillation, and then we can actually switch the patient to long-term anticoagulation in order to reduce the future stroke risk? Now, as I said, the longer monitoring at this moment, the evidence is C. So, there is not quite guidelines to suggest that we should monitor each and every patient in a longer period of time, like 30 days or for 18 months. But it is important to identify some key patient population who may likely be benefited for longer term cardiac monitoring, so that we can increase the yield of atrial fibrillation and ensure cost effective treatment with the help of oral anticoagulation in the long term. So, how we can actually identify those patients? Now, very simple few tests like an ECG. If you do an ECG and in the ECG we find atrial premature complex, these patients are actually having higher risk of developing atrial fibrillation in future, and chances of getting atrial fibrillation over the coming months may be higher in this particular subset of patients. Similarly, in the 24-hour Holter monitoring, if we get more PSEs or premature atrial complexes, particularly in the EMBRACE study, it has been shown the detection rate incrementally increased from less than 9% if there is a less than 100 atrial premature complex in 24-hour tape to 40% if there is 1500 atrial premature beats in the 24-hour tape. So in a fast Holter monitoring, if you get a lot of premature atrial complexes, this subset of patients may be the subset of patients where we can think about doing longer term monitoring either with a 30-day tape or with an insertable loop recorder. Similarly, older age is an independent predictor of having atrial fibrillation in the future and having stroke in future. Another ECG criteria is a prolonged peer interval, which can also give increased chance of having atrial fibrillation in the coming days. One biochemical parameter, that is NT-proBNP, even the patient is sinus rhythm and patient have cryptogenic stroke, if the NT-proBNP is high, these particular patients can also develop atrial fibrillation in future with subsequent event. So, in conclusion, ESUS is an entity where longer time monitoring unmasks occult atrial fibrillation. Detection of AF is important to decide about long-term anticoagulation treatment for secondary prevention. There is poor correlation of duration of AF with future clinical events. Prolonged monitoring for every patient is not recommended, neither cost effective. Risk stratification with clinical, echocardiographic, ECG and biochemical markers can be used to identify higher risk patients for prolonged monitoring in order to detect paroxysmal atrial fibrillation and to decide longer term anticoagulation. Thank you very much.
Thank you, Bikash, for your excellent talk. Now, we have different varieties of pacemakers, each offering different algorithms and different hemodynamic benefits. Dr. Sharkar will tell us whether anything exists like a cost-effective pacemaker. Dr. Sharkar, please.
Good morning, respected chairpersons and dear friends. Now, these topics, is it relevant in 2016? Because we always counsel all patients for a dual chamber pacing. So that is the most effective and that should be most cost effective. Now, it is relevant because, in recent times, the pacemakers are supplied freely to the patient in government setup. I work in a government setup. A few days back, a patient, 85 years old, was admitted under me. And her relatives demanded that she should be implanted a MRI compatible dual chamber pacemaker. Now, so around 130 pacemakers are implanted in SSKM per month. Now, if we started implanting all MRI compatible dual chamber pacemaker, you just think of the cost burden on government and eventually on us. So, there raises the question of cost effectiveness. Now, we always counsel for dual chamber pacemaker on a myth. I will repeat the word on a myth, that dual chamber pacemaker or physiological pacemaker reduces the incidence of atrial fibrillation, reduces the incidence of thromboembolical events, pacemaker syndrome, and it improves the hemodynamics. This myth is going on for last 3 decades, in fact. Now, if we look at the largest meta-analysis on single chamber versus physiological pacemakers, that meta-analysis includes all the largest studies. It becomes around 7,000 plus patients of a 35,000 patients years of follow-up, average age more than 70. Now, there was no difference in the incidence of heart failure or in all-cause mortality between physiological and VVI pacemakers. However, physiological pacing significantly reduced the incidence of atrial fibrillations, and physiological pacing appeared to reduce the incidence of stroke. The authors of this meta-analysis suggest suggested that cautious interpretation of these findings due to borderline statistical significance. There was no additional advantage in several other subgroups that are often considered to derive a greater benefit from physiological pacing. This point to be noted, that is those with left ventricular dysfunction or heart failure. Patients appear to prefer physiological pacing suggested by relatively high crossover rates in 2 studies of this meta-analysis. Now, if we look at a single individual study, single versus physiological pacing in AV block. Now, this is the largest study on this, 46 centers randomized study. And if you look at the age, average age above 70 years, not average age, patients were included above 70 years, where as such the chance of AF, heart failure or embolic event is relatively higher. The primary outcome was death from all causes, secondary outcome was atrial fibrillation, heart failure and a composite stroke, TIA or thromboembolism. Look at death from all causes equal, darker line is dual chamber pacing or rather physiological pacing. Death from cardiovascular causes equal at the follow-up. Atrial fibrillation, interestingly, in the first 1 year or first 1.5 years, there was a shifting of the curve, dual chamber pacer, darker curve, the higher incidence of atrial fibrillation. But this is statistically not significant, and eventually at the end of the follow-up, statistically not significant. Stroke, TI or thromboembolism, not statistically significant. There is a gap between these 2 curves, but it is not statistically significant. And most importantly, heart failure, they are equal, no difference. Median follow-up 4.6 years, but just 3 or 4 years back it was a follow-up of around 18 years. The study concluded that in elderly patients with high-grade AV blocks, dual chamber pacing provided no advantage over single chamber pacing in regarding to survival, atrial fibrillation, heart failure or embolic events. Now, if we look at the studies which include patients both with AV block either or SSS, that is six sinus syndrome. This was a small study. They found no survival benefit, but there was a high crossover rate from single chamber to dual chamber, 26%. This was a large study, CTOP trial, 2000 plus patients, no difference in death from all causes or cardiovascular death. However, there was an 18% reduction of atrial fibrillation, but no difference in heart failure or stroke. If we look at the individual study on six sinus syndrome, single versus dual chamber pacing, this is a small study, but this study showed a mortality benefit from cardiovascular or other causes on physiological pacing in relation to ventricular pacings. I will ask to remember this study. I will mention this study later on. Most trial on six sinus syndrome, again there was a benefit or in relation to atrial fibrillation and a very significant crossover from single chamber to dual chamber in 38% patients. So, definitely a benefit to dual chamber pacing over single chamber pacing in six sinus syndrome. So, if we conclude that dual chamber pacing is, or rather physiological pacing is beneficial to six sinus syndrome, then how can we reduce the cost? We have forgotten a pacemaker mode, in fact that has been relegated in the history, is the atrial pacing. Now, question is why not atrial pacing as a physiological pacing? I will ask to remind you the first study which showed the benefit on dual chamber pacing in six sinus syndrome. This study, this Danish trial was actually on atrial pacemaker. So, this was a trial on atrial pacing vis-a-vis ventricular pacing. This Dan-Press trial is basically a atrial pacing vis-a-vis dual chamber pacing in six sinus syndrome. There was no significant difference in the primary outcome or death from any cause in atrial versus dual chamber pacing. Now, the apprehension on atrial pacing for which this mode is less frequently used was the AV blocks on follow-up. Now, if we choose a patient with a normal PR interval and a patient without bundle block or bifascicular block, then the annualized rate of developing the need for dual chamber pacing becomes only 0.6 to 1.7%. This is a follow-up of around 8 to 9 years, the very lower rate which patient developing AV blocks. During our student sample, we used procanamide to assess the IV blocks, but procanamide is no more suggested. EP study may have a role to decide the AV nodal disease. Now, in AV blocks, someone still thinks that he is going to put a physiological pacing, then the question is why not single lead VDD, by which we can curtail the cost. Single lead VDD pacing provides the physiological benefit of AV synchrony with the convenience of a single lead system and also the cost. However, there are three main objections: the lack of cumulative evidence, concerns regarding atrial sensing stability, and uncertainty surrounding the future appearance of symptomatic six-sinus syndrome. Implantation rate in Europe is around 7%, it is rising. In Spain, it is 19%. However, in US, it is 3%. One of the largest center is our center for pacemaker. For the preceding 10 years, the incidence is just 0%. Somehow, we have not implanted any VDD pacing for the preceding 10 years. If we look at this, it is rather a retrospective study of this around 700 patients of single lead VDD of a follow-up of around 8 years plus. 91% patients are still on this VDD. Only in 0.3% patient there was a AV block, so there was a need for another lead for atrial pacing. So if during implantation someone is getting atrial sensing and implantation between 1 to 2 millivolt with minimum fluctuation, then this will be a very steady atrial sensing and very uncommonly chance that it will develop atrial under sensing. So what is the crossover from single chamber to double chamber pacemaker? All these studies to the long-term follow-up. In UK PACE, largest trial 3.1%, CTOP trial 2.7%. So single chamber pacing is well tolerated. In PACE and most studies, those are in 26% and 36% patient, but only around 40% patient this was due to pacemaker syndrome. So subjective element is in the diagnosis of the syndrome is very high. So if we look at these three largest trials, they suggest that the clinical benefits associated with dual chamber pacing for AV block have been overestimated. It is perhaps counterintuitive that the hemodynamic advantage of AV synchrony do not result in greater clinical benefits. Then what is the explanations? One explanation for this may be the interventricular dyssynchrony resulting from stimulation at the right ventricular apex might counteract the benefit of AV synchrony. This effect might be accentuated by the higher proportion of paced ventricular beats in the dual chamber group. So what is the cost effectiveness of MRI compatible? That will be dealt by my next speaker. And what is the cost effectiveness of leadless pacemaker? It is a early time to comment upon this. So to conclude, physiological pacing reduces the incidence of AF and pacemaker syndrome, does not reduce the incidence of heart failure. I would repeat, does not reduce the incidence of heart failure, does not have any advantage in presence of ventricular dysfunction. Crossover from single chamber to dual chamber pacemaker is mostly subjective. Rate responsive single chamber pacemaker may be the most cost effective pacing mode in AV block. When someone intends to implant physiological pacing AV block, single chamber lead VDD pacing, single lead VDD pacing may be cost effective. Physiological pacing may be the preferred mode in six-sinus syndrome. We can think over again the atrial pacing to make it cost effective. Thank you.
Thank you, Dr. Sharkar. Now I call upon the last speaker, Dr. Minal Das, who will be speaking on MRI, its effectivity and MRI scanning on cardiac devices.
Good morning, everyone, my senior colleagues and friends. Almost all the speakers have spoken about two particular issues. One is the MRI, and second is the cardiac device, especially the pacemakers and internal cardiac group. cardiac loop, which have been spoken by my previous speakers. So Dr. Soumitra has given me the responsibility to clear certain confusions which many a time arise in our minds because of the applicability issues related to the devices with the very important test, that is the MRI, also known as NMR, nuclear magnetic resonance, in earlier days. This particular device or investigation, that is the MRI, is basically an outcome of a very important issue that is related to the spinning of the hydrogen ion, which is abundantly present in our systems, almost all tissues, but they are lying just idle like that, though they are emitting various waves, electromagnetic waves and all. But when they are applied to certain extraneous force like MRI machine or scanner, they get aligned or get anti-parallel, which has been shown in this particular panel, and they emit energy which may be low, but that causes actually this low energy and high energy in other tissues, cause the differential effect and produce the image of the system or tissues. Now with this background, I won't go into the detail of the MRI's principles, but definitely I'll go in certain aspect to the basic principles that are applicable with the devices. Now, so for the cardiac devices are concerned, as you know that there could be intracardiac, like pacemaker, electrode, prosthetic valves, intravascular stents, coils, filters, extravascular pulse generators, ICDs, CRTs, and implantable loop recorder. Now, some of these are weakly ferromagnetic and some of non-ferromagnetic, which have been shown on the right panel. Now, this confusion arose way back in 1983 by Pavlik, Sek et al., where the first highlighting about the potential of interaction between the pacemakers and MRI was there. But so for the stents are concerned, the first approval of the stent came in 1993-94, and it was the Pamaj-Salj BMS stent, which was actually non-ferromagnetic. So there was no much of hallabaloo regarding this use of MRI in the Pamaj-Salj BMS stent. But the issue came again into the limelight when the DA started its journey in 2003, and the various labeling of the stents were made like MRI compatible, or MRI condition, or MRI safe, were given. Now, as you can see, that there is a distinct difference between the two kinds of scans, CT and MRI, and this has been done when it could not detect any lesion, but in a patient with device, but the MRI could detect the lesion ahead of the CT scan. Now, similarly, these device artifacts can be also detected in other forms and with the help of MRI. As you can see that the MRI could detect the mass with its effect on various chambers, but the CT scan could not detect it, but because of the presence of the pacemaker artifact, and the 3D reconstruction also showed the same phenomenon. Now, when the investigation facility with the MRI came forward, there has been surge of these investigations being done over the years, and data shows that it is gradually increasing. And this increase in the applicability is not tallying with the requirement, which I'll highlight later on. There could be interactions between the MRI and cardiac devices. which can be in three forms. The first one is the mechanical forces. The static magnetic field strongly attracts different types of metal. Pacing devices usually contain a small amount of one or more of these metals and are considered to be ferromagnetic. And there is the possibility of movement of the implanted pacemaker. So a 6-week interval between implantation of MRI between the implantation and MRI advised in international guidelines if there is, of course, no emergency. And that was done to ensure the encapsulation, which takes about 6 weeks of time. Similarly, the induction or antenna function can also interfere with the pacing device, and it can suppress the pacemaker, and that is why it was again postulated that that this induction phenomenon should be taken care of, and the 6 weeks phenomenon was taken into consideration. The last one is the software interaction. Exposure to the electromagnetic fields directly affect or modify the electronic circuits and functional settings of the devices, and you are already aware of the phenomenon of reed switch, which can be reset with the magnet, and that can cause alteration in the pacing parameters from either the DDD to VOO or DOO or to VVI to VOO, like that. And that can actually get very much accentuated with the MRI machine, which is a very, very big scanner. The concept of MRI compatible leads and pulse generators for different companies, the strategies have been different. Some offered changes in the software technology, and some offered changes in the lead mechanisms. And most of them, of course, asked for implantation of the screw-in leads for proper fixation so that they cannot get loose even if some heating occurs, which can arise because of the radio frequency waves that are coming along with the application of the MRI scan over the pacemaker. The pacemaker algorithm for compatibility is to be programmed before the MRI test. These are different companies which have given different vendor-specific markers, and this is there are different aspects of the MRI scanners which are to be taken care of while doing the MRI scan in in cardiac devices, and this depends upon the different make of the pacemakers. Now, so for the stents and MRI is concerned, again there was concern because of the implication of catastrophe, and registries were formed in both Europe and US sites and offered patients to participate voluntarily and the doctors to study the application of the technique in a scientific fashion. And conclusion and effects are like this: it may not be necessary to wait 6 weeks or more after implantation of these devices, which will help in the endothelialization, there is actually lesser effectivity of ferromagnetic activity with the most modern stents. However, in spite of the opportunity for recruiting patients in a scanning registry and the experience of not having complications, roughly 50% of the patients, US patients, they do not get the advice or the scanning facility. Now, what are the issues? The issues could be in the form of personnel issue, to appoint someone to the interrogations, and monitoring during the scans. Additionally, the person should not be a device tech. There should be someone trained with ACLS to take care of any eventuality. And in spite of that, some radiologists and electrophysiologists are still unconvinced about the overall safety. However, another important factor is the compensation, which is not usually given if a cardiologist or electrophysiologist stand by the patient. And then there is the problem with the viability studies. The viability study may not be adequately explored with the MRI scan, especially in the anterior wall. The legal issues are also there. There is a distinct possibility. However, if there is proper explanation to the patient as well as the physicians, and they work in tandem and they explain the risk-benefit ratio, definitely this can be and overcome issue. The guiding principles in nutshell, which have been also incorporated in the ESCHA guideline, the general principles are informed consent form to be signed, all the necessary logistics should be ensured, including the SCLS facility, and pulse oximetry offers the status of the heart satisfactorily in case there is a failure of the ECG monitor, which might get altered because of the MRI application many a time. And normal operating function should be exercised. Similarly, the principles applicable to using MRI in patients with coronary artery stents, patients with all coronary artery stents, whether drug-eluting or non-drug-eluting, can undergo the test with 1.5 to 3 Tesla, which is the unit of MRI. And patients with all coronary artery stents can undergo MRI immediately after placement of these implants if there is an emergency. Wait for 6 weeks if no emergency for endothelialization. And similarly for the ICD, CRT, and the CRTDs, I have already said that if there is an emergency, you can go for the MRI, but then if there is no emergency, you can wait for 6 weeks and for the encapsulation. There are certain protocols you can follow, and the conclusion and takeaway message for all: increasing number of device therapies in recent times, increasing the longevity of the patients, increased requirement of an invaluable diagnostic test like MRI in patients with non-cardiac disorders or even unusual cardiac anomalies, and patients should not be denied of this facility. Urgency and utility should be the priority, and the designated centers ensure safety not only to the procedure but also to the physicians, who get a more sort of confidence. And lastly, increasing awareness amongst all stakeholders should be the high priority for the medical fraternity. Thank you very much for patient hearing.
I would request Dr. Das to come and take your seat here. As this has been a very interesting session, we will allow only a couple of questions. Please be direct, specific question to the specific person concerned.
Is it working? My first question to Dr. Bikash Majumdar: many times in Holter, in asymptomatic patient, we see short runs of AF, 10 seconds, 15 seconds. What is the criteria to call it a paroxysmal AF, duration-wise?
Now, any paroxysmal by definition is in AF, which reverts back normally within 24 hours period.
No duration mentioned.
So there is no duration. I don't think there is any duration.
So do you level them in your prescription? If you say 20 seconds duration of AF, one episode in a chance halter,
Yeah.
will you stamp the patient as a case of PAF?
Probably yes.
Dr. Bhora, do you have anything on this? Any comment on this? And I have got one more question later on.
Yeah, I think it's a very relevant point which you have brought out, because it does not specify, the paroxysmal AF definition does not specify how long the duration should be. We have, in terms of ventricular arrhythmia, sustained, non-sustained, and 30 seconds is generally what is taken. So as a practical rule, we do take 30 seconds or longer lasting AF as a paroxysmal AF. But you are absolutely right, there is no data to support this.
And another thing is the short lasting AF, how, asymptomatic incidental AF and their clinical significance as far as
whether
the
you
events
give
is
NOAC or
concerned.
not, that's the whole issue.
We don't know, yeah.
Second to Jayanto, Dr. Shaha, CT angio, what is the realistic radiation burden, and is that reversible after 1 year, or is it a cumulative effect? I mean, whether you can safely repeat another CT after 1 year, or is there a cumulative effect?
Jayanto, mic.
Like any other city.
It's on now.
It has got a radiation hazard, but what is the actual radiation exact amount, I do not know. But it's a very useful clinical test for the low pretest probability for when we want to exclude the diagnosis. That is a very practical situation.
Is there any additional risk? I think the CT angio risk is same as like any other CT. Only the added burden of contrast comes.
Contrast, if there is renal dysfunction and all this, that is a separate issue. But other than the heart rate, that is a practical point that when there is a high heart rate, that's a limitation of image acquisition. But the negative predictive value in the low pretest probability is very important, particularly when we want to exclude the invasive coronary angiography. But the positive predictive value is as well is bit higher, particularly when the calcium score is more.
Okay, Dr. Das Vishwas.
Congratulations, all have done so well. My question would probably go to Dr. Mrinal Das. Often we receive calls from the MRI specialists whether this patient can undergo MRI or not, particularly who are stented. Different kinds of stent, not only coronary, non-coronary, and expandable, self-expandable, stainless steel, non-stainless steel. So what would be your advice in brief regarding the different types of stent and also considering the duration of implant?
Yeah, I have adequately highlighted all these features. The modern stents are non-ferromagnetic, and mostly nowadays we don't use any stent. Sorry? Yeah, and mostly the strut materials that are using the metallic component, these are non-ferromagnetic. And stainless steel is nowadays no longer in use. So having said that, there were concerns because of the fact that there was heating phenomenon after the radio frequency wave that are emitted by the MRI scanner over the stent or over the pacemaker leads. That can cause some injury to the tissues, and sometimes there can be loosening effect of the particular device. So this was highlighted, but somehow or other the registries never showed any complication or even death when they recorded the phenomenon in a distinct way. So it was just a sort of guiding principle that was given, that with the devices which are mostly non-ferromagnetic, you can go ahead with the emergency situation immediately, but it will be justifiable to wait for 6 weeks so that there is proper endothelialization or tissue healing or encapsulation as in the pulse generator cases.
One issue, now present generations may not be having this type of metals, but we use a lot of stents which is based on stainless steel.
Yeah.
So what is your take home on that, those patients?
Yeah, same thing. If we just use that, as I told that even in the earliest kind of stents, Palmer's charge, that was also non-ferromagnetic, but if there are really stainless steel that are being utilized, then possibly we should hold our test if there is no emergency again for at least 6 weeks. That should be the criteria for that.
Even for stainless steel, once it's endothelized, it is 6 weeks is the waiting time.
Sir,
I just have one last question for Dr. M.K. Das. Oh, sorry.
One last question. What about sternal wires post CABG?
Exactly, I was about to ask that.
So they are actually, there is the requirement of withholding the test for some time. Again, the tissue healing will have to be done. Otherwise, there is a possibility of loosening of these wires.
What about the metallic valves?
Metallic?
Valve prosthesis.
Same thing. If it is not steel, then you'll have to wait. But most important issue is with the pacemaker. There are certain aspects where the reach switch activity is involved. There possibly will have to be much more careful rather than the other kinds of devices.
The issue is also with the leftover lead of a previous lead.
That's right.
Anyway, I think all good things must come to an end, and all the speakers have done a wonderful job. We conclude this session here.
Thank you very much, chairpersons and the 4 speakers. While conceiving the program, I thought you will have a bag full of information to take back from this session, but I was wrong. Actually, you needed 4 bags to take the information you got. Excellent, sir.